A flap is a unit of tissue that is transferred from one site to another, that is donor site to recipient, while maintaining its own blood supply. Well, the history of flap surgery dates as far as 600 BC, when Sushruta Shamita described nasal reconstruction using a cheek flap. When then French were first to describe advancement flaps, then in the time of World Wars, pedicle flaps were extensively used. The recent in flap surgery are perforator flaps. So classification. Based on blood supply, there are two types of flaps. Random flaps, they are not named, no named blood vessels are present, and axial flaps. The Mathers and Nahai further classified these axial flaps into 5 types. That is, one vascular pedicle, example tensor fascia lata, dominant pedicles and minor pedicles. In gracilis, 2 dominant pedicles. In gluteus maximus, segmental vascular pedicles. Sartorius, 1 dominant pedicle and secondary segmental pedicles in latissimus dorsi. So this is a diagrammatic representation of the types. See, in tensor fascia lata, gracilis. Now the classification is, we can classify it in 3 types. The first classification was based on the blood vessels. Now this classification is based on the tissue transfer. This can be simple and composite. If simple, we transfer only one tissue, that is skin, fascia, muscle, bone or viscera. In composite tissues are transferred, like fasciocutaneous, example radial forearm flap. Myocutaneous, here muscle and skin transferred, like transverse rectus abdominis flap. Then osteocutaneous, here bone and skin are transferred, like fibula flap. Tendocutaneous, here tendon and skin are transferred. And there is sensory innervated flaps, where we try to maintain the sensory innervation of the transferred flap. And the third classification is based on the location of donor site. That can be local, that is tissue may be transferred from an area adjacent to the defect. So the slight swing posterior thigh flap we did in our case, it was a local type of flap. They can be based on geometric design and include rotation, transposition and interpolation flaps, and advancement flaps include single pedicle, bipedicle and DY flaps. And distant flaps, they are tissue transferred from a non-contiguous anatomic site. Further classified as pedicled means the transferred while still attached to their original blood supply, and free, they are physically detached from their native blood supply and then reattached to vessels at the recipient site. For this, free flap transfer requires microsurgical techniques, and so this is quite tough to do free flaps. So in our case, we did a superior gluteal artery perforated flap. So just a few things. The skin and fat from the mid and upper buttock over the gluteus maximal muscle is included. It is not harvested as a sensory flap. The blood supply is superior gluteal artery and vein via perforators through the gluteus maximus muscle. The vessels at their exit from the pelvis are 3 to 4 millimeters in size. The artery is large caliber artery from 3 to 4 millimeters. The veins are larger of the accompanying veins, can become quite large with a diameter exceeding that of the artery. The pedicle length from the point just between the gluteus medius and piriformis muscles, the pedicle can be up to 7 centimeters in length. So this is the picture where we can see the superior gluteal artery and its vein perforate the gluteus maximus. And we did the posterior thigh flap, so something about it. Skin and fat from the lateral and posterior part of the thigh muscle. Medial anterior cutaneous nerve. This flap can be used for sensory thing. The blood supply is profunda femoris artery. The caliber of the perforators is 0.8 plus minus 0.3 millimeter. The perforators are accompanied by veins. The pedicle length is around 68 plus minus 33 millimeters from the profunda femoris artery. Thank you.